Thank you. So the next talk will be delivered by Dr. Jeyaraj Pandian. Dr. Jeyaraj is a professor and head of neurology at the Christian Medical College and Hospital, Ludhiana. He is also the principal of CMC Ludhiana. He is the current president-elect of the World Stroke Organization. And I'm proud to say he is the first Asian to hold this post, which will be taking up next year. And he is also the past president of the Indian Stroke Association. He was the past chair of the World Stroke Campaign International Working Group of WSO, and he is also the member of the Strategic Advisory Group for the non-communicable diseases in the World Health Organization. And to look at stroke in India, some people say there is a pre-Dr. Jeyaraj and post-Dr. Jeyaraj stroke in Indian context, because he has done so much of work on stroke and especially stroke research, and he has been the main person to set up what you call as the Indian Stroke Clinical Trial Network, or the INSTRECT. And this is a large network which he is heading, and I'm in fact very grateful for him to having nudged me into this. And initially I was very reluctant, and now CMC Vellore is having so much of research projects because of his encouragement. And he's also the national, he has also many publications and more than 250 peer-reviewed publication and H-index of 62. Over to you, Dr. Jeyaraj.
Thank you. Thank you, Dr. Sanjit. And first of all, I thank the Department of Medicine, Dr. Anand Zakaria, for selecting this theme, and also for inviting me to give this talk on equitable access to stroke care and prevention in India. So this slide shows the burden of stroke. If you look at your left side, the upper corner, the incidence is 12.2 million. This data is 2019, and prevalence is 101 million. And if you come to this side, this is the cost for stroke, about 861 billion US dollars. Then I'll take you back to the other corner, where out of 101 million strokes, if you come to this figure here, almost 58 million prevalent strokes are in Asia. And if you look at that other graph, 80% of the strokes occur in people with low to moderate risk. Many of us know the Framingham risk score, and that picks up high-risk patients. But here, 80% of strokes occur in people with low to moderate CVD risk. And 1 in 4 people will have a stroke in their lifetime. So the bottom panel depicts the common risk factors. Number 1 is hypertension. If you look at prevention of stroke, you need to just target hypertension. I will cover that during the talk. So the risk factors in South Asia, this is the GBD data, and number 1 is hypertension. So there are other risk factors like diabetes, air pollution, indoor air pollution, etc. The stroke burden in India, quickly I will summarize. This is a recent systematic review. Our India-UK group, it published prevalence is known, some of the older studies without CT scan, and also including one landmark study from CMC Vellore in 1960s. It was 26 to 757 per 1 lakh population. Incidence is 119 to 152. Case fatality rate is, that is the number of people who die after 1 month, is 22 to 42%. And there are regional distributions. You can look at the eastern coast of India, a little bit of northeast, and Punjab, Himachal Pradesh. There's very high prevalence of stroke. And I'll come back for the reasons why there is a high prevalence of stroke. And from the latest incidence studies from Ludhiana and then the ICMR the NCDR Bangalore had recently published in 5 places in India. So the Ludhiana urban population-based registry, it was 130 per 1 lakh population, and the case fatality rate was 22%. So this slide is important. This none of the incident studies published so far in India has not addressed this. So who are the people who have poor prognosis? The people who are 60 years of age and people who access government healthcare system. And you can see the striking difference. It's a short follow-up, 28 days, and you can see the difference in terms of healthcare system. So I'll come to this, how we can tackle this disparity and equity problem. The Ludhiana rural population-based stroke registry, 130 is urban incidents, and if you look at the rural, it is close to 200. And we just saw the alcohol problem in rural and urban. It's almost similar, but here you can see the incidence is very high in rural population of Punjab. And mortality, this the first proper mortality data for stroke at population level was published from Gadchiroli, India. I think Dr. Yogesh is here. I'm not sure. So basically a verbal autopsy of all the deaths in these villages, and 1 in 7 deaths in these villages are due to stroke. So that is the burden in rural, this is a tribal area. And then we have our own unpublished data from Ludhiana Rural Population-Based Stroke Registry. Here, 1 in 4. Punjab villages are developed. And compared to a rural or a tribal village in central part of India, here's 1 in 4. Most of the stroke deaths documented at government data, it's an underrepresentation because cause of death, cardiac arrest. Even stroke patient dying is marked as cardiac arrest. So the only reliable good data we have is from the verbal autopsy studies that has been done in India. This is the recent publication from NCDR Bangalore. So they looked at this surveillance model and they expanded to 5 regions of the country. And the data is almost similar. If you look at the incidents, there is some variation, regional variation, but it's around 130, 140. And case fatality rate also, if you look at, it's close to about 20 to 42%. That is the range. And through ICMR, there's another registry was completed in Dibrugarh. I showed a map where northeast there is a high incidence of stroke. And here is completely different, the proportion of patients with ischemic and hemorrhagic stroke. In the rest of the country, it is about 23% hemorrhagic stroke. But you go to Dibrugarh, it was more than 60%. In one particular year, it was 72%. And we have a program in Tezpur Medical College and Dibrugarh. In Tezpur Medical College, 72% of the strokes are hemorrhagic stroke. In Baptist Christian Hospital, 54% of the strokes are hemorrhagic stroke. So this is a disproportionate burden of ICH in this part of the country. Incidence is almost similar, but the proportion of ICH is completely different. So I'll just skip this. So in summary, stroke burden, we have a very high prevalence of stroke, incidence, mortality is high, and there are regional variations, particularly with Northeast India. So with this high burden of stroke, how can we address or how can we reduce the burden of stroke? So this slide shows a table where in the left-hand side, all the evidence-based interventions that are available for treating acute stroke, which includes aspirin in ischemic stroke within 48 hours, thrombolysis, intravenous thrombolysis, mechanical thrombectomy, management in stroke unit, and rehabilitation. So this slide basically what it shows is that what intervention has a maximum population benefit. Now, whatever we do, we need to look at the population impact. This population impact for a million population of 10,000 strokes. And So stroke unit has a maximum population benefit. If we want to develop care program, you need to look at what is the best intervention that will have a population benefit. So that is why stroke unit care has a maximum population benefit. But there are several barriers, and the barriers at healthcare system level, that is the infrastructure, lack of human resources. There are only about 3,000 neurologists in this country, and most of them are in southern part of India. And there are several states in North India, even in Punjab, in government sector, there's only one neurologist in the government medical college. So much of disparity and in terms of human resources. And if you come to the nurses, again, there are issues, therapists. So again, there is a lot of disparity. And patient level, lack of awareness about stroke warning symptoms and signs, where to go, even if they recognize where to go, which hospital, and the cost of treatment. The intervention, which I mentioned, thrombolysis is expensive. If it is recombinant tissue plasminogen activator, it's about 58,000. And if it is tenecteplase, it's about 36,000. Mechanical thrombectomy in corporate hospital is about 5 lakhs. But in Ayushman Bharat, it's about 1.8 lakhs. And we have just revised to about 3.5 lakhs. So cost. So these are the several barriers that we have in the healthcare system, both at the hospital level as well as the patient care level. So this is one of the recent publications, which addresses the disparity in this region and commonalities, disparities, and Dr. Sanjit was also part of one of these papers, stroke burden and stroke care model systems of care. It is free to download. You can later on check on this. And so it's one table I want to show in terms of availability of infrastructure. The stroke unit is mentioned, IVT is mentioned, EVT. If you look at Indian data, there are about 400 stroke units, and IVT capable centers about 595, EVT capable centers are about 365. Physiotherapy is about 14,000, occupational therapy is about 6,000, speech and language pathologists about 1,700. So this is the figure that we have from India. So with these barriers, and how can we develop stroke care in our country? And most of the stroke units are in private sector hospital. So from World Stroke Organization, we have a global stroke roadmap. That is, we have classified the healthcare facilities as minimal stroke care services, essential stroke care services, and advanced stroke care service. Minimal is equivalent to our health and wellness clinic or primary health center. What can we do at primary care level? Rapid identification of stroke symptoms and check the blood pressure, blood sugar, and immediate referral to the district hospital or the right hospital to do a CT scan. District hospital, you have a CT scan, you have a physician, you may not have neurologist, and you can give intravenous thrombolysis and some amount of rehabilitation. In an advanced stroke care services, a tertiary care center. So I will discuss few important models that has been implemented in India. One is a hub and spoke model in government sector hospital. So earlier from the Ludhiana registry, I showed a figure, patients who are managed in government hospitals had poor outcome. So we need to really target the government hospital. So this is a model developed by one of my colleagues from AIIMS, Dr. Padma, and the neurologist from Shimla Medical College. So the two hubs, Shimla Medical College and Kangra. You just imagine the MLS and the terrain and how quickly the patient will reach. And they were able to show successfully using WhatsApp, and they were able to treat acute stroke patients and thrombolyze acute stroke patients. And in Punjab in 2016, we started the program with Punjab government. We trained the doctors, nurses, and then we had multiple smaller trainings in district hospitals. We went there and trained them, and it is a physician-based model. Stroke units were established in these district hospitals. IVT was free of cost, and it was linked with 108 ambulance service. So for 1 year, we had good data. About more than 1,500 patients were treated in these district hospitals and government medical colleges. 5% came within window period, that is 4.5 hours, and 3.6% of them received thrombolysis. Just by training, capacity building, hand-holding, and a little bit of using WhatsApp, a program was established. But our COVID came and everything got disrupted. We have restarted the program. In Kerala, through Sri Chitra Institute, they are the hub, and the other district hospitals have stroke programs. And Tamil Nadu, we have the Tamil Nadu Accident and Emergency Program, where it is an integrated model of acute MI and stroke that has been linked. And people can find out which are the stroke-ready hospitals where they can go. But however, we don't have any data how many patients have been thrombolyzed, how many patients of acute MI underwent PCI. It is there with the government, but it has not been shared publicly. In a similar model in West Bengal, the Bangalore Institute of Neurology in Kolkata, they are the hub, and they have developed multiple spokes with 24/7 availability of CT scan. Even though it's a good hub and spoke model, but the 108 ambulance is not integrated well. So all the patients reach the hospital by their own conveyance, and about 600 patients they have thrombolyzed using. And they have a very good telestroke system, not WhatsApp, a proper system. Image is uploaded to Bangalore Institute, and they take a call, neurologists take a call, and then treatment is provided in the district hospital. So we have successful hub and stroke model in our country. And one of the problems is access to CT scan. So can we take the CT scan to the doorstep of the patients? So this model was from Indian Council of Medical Research. The previous Director General, Dr. Balram Bhargav, during one of the conversations with him, he said, I have huge amount of funding for Northeast research. Can you write a proposal on mobile stroke unit? So I thought it's a crazy idea, and why should we spend huge amount of money there? And there's no neurologists in most of the places. But anyway, money is there, so I thought 2 weeks I'll write the project. It's one of the fastest approval I have got for any research grant with ICMR or any other funding agency. So we need to identify a place. So Tejpur already we had established a stroke unit. I think late Dr. Lydia John, who's a graduate of this place, she started the program there. So I thought already we had some capacity building there happened. So let us use Tejpur Baptist Christian Hospital. Then it's the government money, so we need to involve the government's hospital. So Dibrugarh Medical College and Tejpur Medical College also were involved. So this was deployed during peak COVID by our former Health Minister, Dr. Ashwardhan. We had a lot of teething problems. This is a Tejpur group. Again, Jamin Webster is CMC Valor graduate. And then now Jacob Johnson is internal medicine from here. He is running the program now. And Binod Sharma is a neurologist. So in summary, what I can say is MSU calls have improved, increased post-COVID. They have thrombolyzed close to 10 patients in MSU. And again, I mentioned 70% of the strokes are ICH. Even in MSU, you do a CT scan and then it turns to be intracerebral hemorrhage. And in the Indian Stroke Clinical Trial Network, we have a trial called tranexamic acid in ICH, acute ICH, within 4.5 hours. And both Dibrugarh and Tejpur have randomized patients in the MSU within 4.5 hours. So they were able to give the drug in the intervention arm. So this pre and post MSU, there are certain improvements that has happened. One, the use of ambulance, any ambulance service, is a tea garden ambulance or a taxi or 108 ambulance, it has increased. And the door to CT time is reduced, but is not significant. It reduced by 2 minutes. Door to needle time in the hospital, thrombolysis in the hospital, reduced by 5 minutes. But thrombolysis rate in the system, in the hospital, from 0.8% to 3.6%. It is creating a stroke care pathway by creating awareness among the public, taking the MSU. Now the project is at the final phase, and we are going to submit the report to the government, and we will know whether they want to scale up in remote areas where there are no neurologists. So I'll talk about mission hospitals. Now, we have worked with few mission hospitals. Manali, Tejpur, already we established the program. Makunda, then Padar, Vadanjatram, and Kotagiri. I'll just talk a little bit about these programs. Through World Stroke Organization, one of students, Dr. Ivy Sebastian, she was a part of the Future Leaders program. She got funding to test this model in multiple countries, Armenia, Malaysia, and India. So in India, we identified 2 centers, Makunda, but they do not have CT scan. And Padar, they had a CT scan. So it's, as part of the project, they developed an app. It was basically a capacity building using the various modules, and then assessment was carried out. In phase 1, it was the CAP pre and post with a knowledge retention, and phase 2 was implementation of stroke unit care, and then the key quality indicators assessment. It was very simple, and in 3 countries it was implemented. There were some videos, protocols, and the doctors and nurses were able to see and implement things. So in summary, what I would say is the CAP improved, and there was knowledge retention after a few months using this method. And in terms of key performance indicators, country-wise, actually the Padar and Makunda did very well as compared to the other 2 countries. And the key performance indicators like increase in swallow assessment and the change in the hospital stay all improved in the. So this is again a model. We are able to do it in the mission hospitals. The Kotagiri hospital, Dr. Tony Abraham, who's a neurosurgeon, who's there. They have a CT scan. So we got a request from them. There are so many stroke patients who are coming. They can't be sent to Coimbatore. You lose a good amount of time. And so we had about 3 sessions with them. And these are the, they started a dedicated area, stroke unit, I think 2 beds, if I'm correct. And these are some of the patients who have been treated with thrombolysis. And they have given TNK in about 6 patients. The program started in August. So in one of the patients who had a large vessel occlusion, I told him you give TNK and send to Coimbatore. But the relatives did not want to go to Coimbatore. So in remote areas where you don't have access, simple capacity building will really help to treat these patients. And even in CFH Vadanjatram, Dr. George Philip had come and worked with us for a year, and he has started a stroke program there. And he has given about 5 thrombolysis. Then prevention. So I'll move on to the prevention. There's a huge burden, but if you want to show significant reduction, we need to target the risk factors. So what are the ways that we can prevent stroke? So this slide summarizes the primordial, this primary, and the secondary prevention. Many of the modalities will be common for all these categories. And so in primordial, again, we need to look at healthy cities. Even in people who are young, you need to look at their lifestyle and healthy lifestyle. In primary prevention, you have tobacco cessation, using mobile health, task shifting, using the frontline health workers. There's a WHO PEN approach at primary care level. You can do salt reduction, healthy diet, and polypill. So there are many strategies that overlap, and these are the evidence-based intervention that can be used for large-scale population prevention and also individual approach. So this is one policy paper from World Stroke Organization using polypill, and there is evidence now with multiple trials done in both high income as well as low and middle income countries, and using community health workers at primary care level, empowering them, ASHAs, and there is a lot of evidence, particularly an integrated approach of reducing heart attack and strokes. And we have this India Hypertension Control Initiative, which received the UN award, where at a health and wellness clinic, screening for hypertension by the frontline health workers, there is a fixed algorithm and drug availability. And this was rolled out in about 26 districts and 5 states. We were able to show the BP control from 1.4% to 5%. And this program now is being rolled out along with adding diabetes mellitus. So now it is in the Ministry of Health and Family Welfare across all the states. So this is probably the best way, I would say, to reduce both heart attack and stroke in our country, and other NCDs like CKD. So secondary prevention, this is where we all struggle. Patients we treat, we advise them, we send them home, and then 3 months they take medication, they'll come back. They would have stopped the medication and they'll come with recurrent stroke. This is a big challenge. At population level, okay, education, screening, give medications, and you try to control. But in secondary prevention is a major challenge. We looked at this in a trial called Sprint India trial, where we use text messages, videos, and workbook to change the lifestyle or improve the lifestyle of the stroke patients. And we followed them up for 1 year. This was a large trial funded by Indian Council of Medical Research, which was done in the Indian Stroke Clinical Trial Network. We randomized about 4,298 patients. The primary outcome was recurrent vascular events. There was no difference, but in behavioral intervention like smoking and alcohol cessation, there was a significant difference. And also medication adherence improved with this methodology, with this intervention. So if we had followed these patients for 3 years, 4 years, we would have seen the benefit in primary outcome, but because of shortage of funding, this trial had to be stopped. But what lessons that we've learned from the intervention that we had, the 3 interventions, the only thing that will really work is the videos. If you are able to provide or prepare or videos of 30 seconds of education for education purpose, that will have a huge impact in terms of change in lifestyle. Then population-based strategy, I'll just quickly summarize 2 studies. One we did in Ludhiana, another one in Trivandrum in Kerala. Basically, people with high blood pressure and who had a stroke, we had a protocol. We trained the ASHAs in the villages. So the ASHAs in 2 blocks, they were trained, and they had this called stroke Rok kit. Rok means stop in Punjabi, which had a manual BP monitor, glucometer, and a mobile phone. And they were able to communicate. They used to go to their homes and measure the BP and sugar and communicate with the neurologist. What we found was we were able to show reduction in blood pressure and both systolic and diastolic, and also blood glucose at 6 months using ASHAs. A similar study was done in Kerala from Sri Chitra, and they were able to show some behavioral changes using this intervention. But what I want to say is, for secondary prevention also, we can use the frontline health workers to reduce the recurrence of stroke. So lastly, I'll just touch upon, we know as physicians and healthcare professionals, we screen, treat patients, and then what about policymakers? Without involving them, we may not be able to bring in changes. So through WHO Southeast Asian Regional Office, we had this opportunity to work with the 11 countries. We started with 4 countries, Bhutan, Myanmar, Timor-Leste, and Maldives, and in phase 1. And basically what method that we used was capacity building, like previously what we did with some of the mission hospitals and the government hospitals. Capacity building, training, and empowering them, giving them tips. And most of the things were done virtual. And we had the opportunity to visit the Bhutan, and they had developed stroke units in 3 places, and another 2 they have started recently. And with WHO head office, we are coming up with a strategic roadmap for not only stroke, but also for cardiovascular diseases. So this is at a higher level. When WHO says something, the country officers listen and the ministries listen. So this is the top-down approach by which we can influence policymakers. And within India, the health is a state subject, even though you have national programs, but finally the state governments have to implement. So this is one opportunity that this year, we were able to meet Honorable CM of UP. UP 72 districts, and I think they have about 23 medical colleges. Only in about 4 or 5 corporate hospitals we have stroke units. So we have laid a stroke action plan for UP, and we are going to again meet with the health secretaries and do it. And through a India-UK program, an NHR grant, we are able to do capacity building with Punjab government doctors and nurses, and also had a dissemination meeting in Delhi in June 2023 with the WHO country office, CRO, ICMR, then the NABH, National Health Authority. It was a small meeting, but we were able to impress upon the policymakers about the importance of stroke. And just before G20 from World Stroke Organization, we organized a ministerial meeting for Southeast Asian countries. About 17 representation came from India, and 7 countries sent their representation. So there was a New Delhi declaration which was signed, and also a certification program with NABH, which is just rolled out now, and soon there'll be a portal open by the NABH, and people can apply for stroke center certification. Just few days ago, I was in Tezpur with the same India-UK group. We were able to conduct a training program for all the Assam doctors and nurses, and the health minister had come. And so this is another way of influencing policymakers of what we have demonstrated in different models, the interventions, how we can scale up and work with the governments. So I will conclude. So equitable access to stroke care can be provided, even though many of the therapies are expensive. And in Ayushman Bharat, the entire stroke care is covered: neurosurgical procedure, thrombolysis, thrombectomy, stroke unit care, everything is covered. And several models of care are available, and population-wide prevention strategies are the way forward, and like what is happening in India Hypertension Control Initiative. And it is up to the state government to roll out this universal health coverage. And many states are still sticking on to the first payment reimbursement, even though there has been subsequent changes that has been made. And only last week, we finalized the revised package for stroke thrombectomy. It's going to be about 3.5 lakhs. That is pretty reasonable, even for a private hospital. And most of the thrombectomies are done in private hospitals. So with that, I conclude. Thank you very much.
Thank you, Dr. Jeyaraj. We'll take some questions. The first question is from Krishna. I'm sure, like for us it is Pulmoner, nearby place, and they come late, often only fit for decompression. So, what is your? I'm sure, like you having gone to so many places, how to tackle this?
So in Ludhiana also, the villages, we have two places. Both the unqualified practitioners, they give intravenous fluids. They mix B complexes, whether it's yellow or red, and sometimes they give dexamethasone, also steroid. So they all have a very good feeling that they are getting treated. So when we did this urban survey, when our health, the research staff went to the villages, they got threatened. No, they are running this practice for years and generations. And they have a big network, political network. So for us to go and talk to them and tell them what you're doing wrong, it's not going to work. So the only way is, raising the awareness of stroke among the public. That is the only way we can tackle. Even if you go to the government and to ban them from practicing there, it's not going to work. They will do the backdoor work, and then still they'll be practicing. So the only way is raising public awareness.
Thank you, Dr. Jeyaraj. I think there were some questions. Whoever wants can meet Dr. Jeyaraj over the coffee break. Thank you.
Yeah, thank you. Thank you very much.
I would like to ask Dr. Sanjit to present the memento to Dr. Jeyaraj.
Yes, yes.